It's my pleasure to be here with you again. Can I just have a show of hands? How many folks are new this year? So a lot of you, and then and the rest of you then, so it's about half and half or a little bit more. So I'm coming back. I presented a talk last year on this same topic, so I want to perhaps give a little bit of overview for those of you who are new, but not too redundant for the folks of you who heard me speak last year. So we'll be talking a lot about what the problem is, but some of the strategies we've used to address it and progress that we've made in addressing the opiate epidemic. So just the scope of my talk, I'll talk a little bit about the current data that we have in Oregon and what it's showing around opioid overdose, some of the statewide and community strategies that we're using, and then I'll really focus a fair amount on our opioid prescribing guidelines that were just newly endorsed, and then end with some of the other initiatives that the Oregon Health Authority has been involved with. So the scope of the problem, Oregon is tied for 4th in the U.S. in non-medical use of prescription opioids. So, of course, the problem is not only are we prescribing those opiates, but at what quantity and what opiates are not being used and left in the medicine cabinet, and then when are people taking those. So this, our survey, self-reported on survey, but we're 4th in the U.S., so that's over 200,000 Oregonians, or 5% of adult population. 9% of 18 to 25-year-olds report that they are using opiates for non-medical reasons. In terms of, hospitalizations, we have approximately 330 hospitalizations for opiate overdose, and an additional 4,300 hospitalizations related to opioid use disorder, resulting in $8 million of hospitalization charges. And of course, this isn't to speak about all the other medical visits and time lost from work and those kinds of things. So it is a huge economic burden. In 2014, we had 154 people who died, so that's one death every other day in Oregon. Someone dies from an opiate overdose. So this slide shows the good news and the bad news. I think the good news, the top line is in red. These are opiate overdose deaths. It went up dramatically. When people ask me, why are you using the word epidemic? This is the definition of an epidemic, something that, a drastic increase in the number of cases. But it did level off at the end of the 2000s and has slightly declined. Now, of course, I'm concerned not just about people dying of prescription drug overdose, but whether they're dying of other drugs as well, or in combination. And so the second green line here, heroin, you can see that that increased dramatically just at the time that the prescription opioids were starting to decline. It's leveled off. It hasn't continued to increase exactly, but again, we want to be sure that when we're limiting prescription opioids, that doesn't necessarily mean that people go to the illicit market. The bottom line are psychotropic medications such as benzodiazepines. Those are particularly dangerous in combination with opiates, and you can see that that purple line has gone steadily increased. So when I talk about opiate prescribing or overdose, that's a problem, but so are these other medications that are central nervous system depressants that can also lead to death. So by age, the youngest age group is here on the left, the 18 to 44-year-olds, and then 45 to 64. And this slide shows a couple of things. One, the highest overall death rate is in the middle-aged adults, 45 to 54. That's the blue bar, but is followed closely behind by the 18 to 44-year-old. But the drugs they're taking are a little bit different. The pharmaceutical opioids or prescription opioids are higher in the 45 to 64 and lower in the 18 to 44, whereas heroin is higher in the 18 to 44 and a little bit lower in the 45 to 64. So again, for my purposes, it's important to know that when people are talking about, for example, heroin overdose or opiate overdose, it isn't just heroin in the younger population. It is prescription drugs as well, but we really need to look at all of them. Now, this slide shows some good news. So we and the Oregon Public Health Division, we're the folks who monitor the prescription drug or oversee the prescription drug monitoring program, which I hope you all have signed up for and are using. And so we can monitor how many drugs or what are being prescribed each month. And so this is a little busy, but it's looking at opioid prescribing by quarter. And in the last quarter of 2016, we started to see a slight decline. So you can see it's not drastic, but we're starting to see it edge down. So again, this is good news. We're starting, and what I hope, we have to continue to monitor over time, but not only are we starting to see a decline in the deaths, but we're starting to see a decline in prescribing practice as well, which will hopefully lead to that continued decrease in overdose deaths. So when we talk about the initiatives that we have in Oregon, I think about them in these three very broad buckets. The first is we have too many drugs out there. There are too many opioids. And we really need to figure out how to limit the amount that's being prescribed, both the number of prescriptions and then, of course, the number of pills that are included in those prescriptions. And in order to do that, it's not so much that we really want, that it's just stop using opioids. You need to be able to offer patients alternative. And so we're looking at increasing what the different alternatives are, especially for chronic pain. We need to promote access to naloxone rescue. And again, in my mind, naloxone, as you know, is really a rescue medication when somebody has overdosed. So it's really pretty far down. It's not, as I would say, a primary prevention. At the same time, not only do we not want people to overdose, if they have, we don't want them to die. And so we're trying to improve or increase availability of naloxone. And then, again, there are lots of patients now who are on that sort of wave, having gotten a lot of prescriptions for opioids in the past and have a lot of tolerance and are on very high doses. And we need to have a compassionate way to taper folks off, so increasing the availability treatment for opioid use disorder. And then the third big bucket is to make sure that we're using data to drive this and trying to see where it is that, whether we're making impacts in what's happening, which parts of the state, which communities are most affected, et cetera, so we can help to target some of our prevention programs. So I'm really going to focus mostly this talk on the first bucket. I will talk a little bit about the others. We have many people in the Oregon Health Authority working on this, so there's more details at the end if folks want some context specifically about medication-assisted treatment, for example. So in March of 2000, we've been thinking about opioid prescribing guidelines for a while, and several parts of the state actually had developed some guidelines. I think the Southern Oregon had developed opioid prescribing guidelines about 5 or 6 years ago now, so they were sort of ahead of the pack. Washington State similarly had them. So we were thinking that it would be useful to have statewide guidelines, and then the Centers for Disease Control, I should say luckily, it took us a few months to get off the ball, because then the CDC published national guidelines, and so that was very helpful to have them as kind of a groundwork for what we might want to do statewide in Oregon. I think it's important that these guidelines really are focused on chronic pain, not cancer pain, palliative care, end of life. There are some exceptions. Now, acute pain isn't directly addressed by these guidelines, but it is alluded to, and of course, chronic pain starts with acute pain, and the first long-term opiate prescription starts with a single prescription at some point in time. So it is important for us to think about what's happening with those acute prescriptions as well, and at what point do they turn into chronic use. So the CDC guideline actually has 3 large buckets, and in each of those they have a number of different recommendations. And so if you all haven't looked at those, they're very thick. It's about 200 pages. I would highly recommend using them as a reference document. They were helped pull together. Dr. Roger Chow, who's with the OHSU's Center for Evidence-Based Practice, was one of the co-authors, so extensive review of the literature. And again, I think they're a very good guide, I wouldn't say. And if you go online, CDC actually offers CME specifically if you go through the guidelines and you click, so you can actually get CME for reading the guidelines. But the categories were when to use opioids for chronic pain. And again, alternative pain management options are preferred. Try other things first. And the real focus is that the treatment goal is not so much on the pain itself, but rather maintaining function. And I think that's a little bit of a paradigm shift. We all know that when you come into a doctor's office, or you all as healthcare providers, it's one of the vital signs you ask about pain. Well, that's fine, except as soon as you ask, it's presumed that you're going to do something to treat the pain right then. And we need to be focusing less on the pain itself and more on making sure that people can function. So obviously those two things go hand in hand. I'm not saying we shouldn't be addressing pain, but we need to be thinking about what the expectations are for that. Discussions of the risks and benefits of opioid treatment really need to be done at the time. There was a study that showed, I think it was done in the military, that they offered naloxone at the same time as offering an opiate prescription to say to those patients, you know what, it's not you, this is a very powerful drug, and here's a rescue medication. And actually, people took less opiates because they then realized that these drugs were as potentially dangerous as they were. So the guideline also talks about opioid selection, dosage, duration. Start with very low dose, short acting, minimum time frame. Don't, again, give large quantities of pills so that, I mean, you know, the classic is sort of 30 pills and this kind of thing. If people are only needing a few, prescribe a few. And I understand there's several hurdles to this, which include things like, well, how many, you know, refills do you get? And do you want to be called every time for a refill and this kind of thing? But I think we need to get beyond that, because what's happening now is just the opposite, that people are giving large quantities. Some people take a few, and recall my very first slide where a lot of those unused medications are being used for non-medical purposes. And then doing a risk assessment and addressing harm. So again, the prescription drug monitoring program can be part of the assessment about what different medications your patients are on and who else they have seen to get prescriptions. And then they address the limiting co-prescribing. So the CDC guideline, again, was a great foundation. We in Oregon then decided, again, I had it in mind that we needed to do this, but that it was really important for us to have some Oregon-specific discussion of these guidelines and really endorsement of those guidelines in order to adopt them statewide. So we pulled together a task force, and the goal was really to set a standard for prescribing across the state, including various health systems, practice setting, providers, et cetera. Because what we didn't want is for one provider setting or health system to say, well, we're not going to prescribe, here are our guidelines, and then the patient says, well, fine, I'll go across the block to this clinic or whatever. We really needed, everybody needs to be in this together. And similarly, we've certainly heard stories that, you know, one of the goals of opiates is to make sure that they are, or these pain management is being done in a primary care setting, but then what happens when the patient has an acute event on the weekend, and then the, you know, so then the emergency department is giving them, and then there's sort of back and forth, well, we can't give them, you need to go to your primary care. And the primary care says, well, I'm not going to do the refill. We need to be sure that providers are on the same page, because it really, again, this is very hard, but that's a lot of what happens is that we hear from different providers, well, so-and-so did this, and so-and-so. We're all in this together. And that was really the goal of the statewide guidelines. So membership on the task force were different professional associations, licensing board, provider organizations. Kevin Iwancino was on our task force, and as part of the work that you all have been doing here in the Central Valley, health systems, hospitals, regional task forces, et cetera. So we had a broad range of provider groups. These were also public hearings, and so we did have some citizen input at some of them. The task force met from June through November, and the guidelines are posted, so I would encourage you all to look at the Oregon guidelines at healthoregon.org/opioids. And then, of course, what I always say is the guidelines were actually the easy part. The hard part is how do you communicate them and how do you implement them. And I think the communication is, of course, I'm talking to all of you, and I've talked to a number of people. I've given talks also to different legislative committees, et cetera. But it's an understanding that from the patient perspective as well, what is it that they can expect when they go into a doctor's office? So the task force elected to endorse the CDC guideline as a foundation, but that there were some Oregon-specific addenda that they wanted to see in the guideline. And so, again, these slides are a little bit busy. I know you all can download these and have them, and I would encourage you, again, to both look at the guideline and then download some of these slides for the detail. But I think a lot of this was really looking at those CDC buckets and what were the additional things that we could help providers in Oregon do. So for one of this category around prescribing higher opiates, there was a lot of discussion about what to do with patients, for example, who potentially need higher doses. And what we said was to sort of have good practice that was consistent, have a pain management consultation, have a colleague also evaluate or discuss it with a clinician peer group, refer to a pain specialist or a pain and addiction specialist. And again, we understand it's very different in the Portland metro area or here in the Valley than it might be in Eastern Oregon. And that's why we wanted to offer some ideas that people could just talk to another colleague, for example, or it could be a phone consultation. But we really wanted this to be a couple of folks being consistent about what was needed for those patients. And really compassionate treatment for those patients taking higher doses who've been on them for a long time, these so-called legacy patients. But we really know that we need to figure out how to taper them off, but do so in a compassionate way. Use of the prescription drug monitoring program, and the idea here was that it really needed to lead to discussions about opiate use, not necessarily dismissing patients from practice. Urine drug testing was another one that we looked at, and again, there are a lot of, it's another tool. It's not the be-all and end-all, but it's a tool for a couple of reasons. One is to see, are they taking opiates like you prescribed, or is there some diversion? Another is potentially, whether the doses are too high, what other medications, and those kinds of discussions. So it can really lead to a conversation. This is a piece of other information, not that concrete decision should be made based on the results of that. And then I had mentioned the co-prescribing with opiates and benzodiazepines. There are a lot of folks, obviously you're in chronic pain, that can be a very stressful situation, and some of these patients are also on anxiolytics. Now we know that's a dangerous combination, but again, having a discussion, it may be that certain patients really would benefit from small amounts of one or this being closely monitored. But again, we wanted to be sure that if someone was making that decision, they were doing it in conjunction with others so that it could be considered kind of a standard of practice within those patients. And then having that informed discussion about the very serious risks specifically of the combination. So the big topic that everybody asks about is, what about marijuana? The problem, or the issue I should say, is that Oregon has had medical marijuana since the late 1990s, and we have about 70,000 patients now on the who get Oregon medical marijuana cards. But of course, we passed retail sales a couple of years ago. So marijuana use in Oregon is extremely prevalent. Among marijuana card holders, over 90% of them report chronic pain as the reason that they are getting a medical marijuana card. So the flip side of this, of course, is that many of those patients say, well, I'm doing it for chronic pain, and therefore I don't need very many opiates. But the data are really limited on what the interactions are. And so that's one side of it. People will say my marijuana helps me use less opiates. And other, particularly physicians, would say, well, you know what? I'm actually very uncomfortable with having people use two of these, psychoactive medications. How are they able to actually follow through with some of the pain management things on this side if they are, under the influence of marijuana? So rather than coming down with any solid, either do or don't sort of thing, what the group came up with is that it's really important to have to discuss and document how your patient is using marijuana. Occasional use on a weekend is very different than patients who are on medical marijuana who are using very, very high doses of THC or CBD on a daily basis. And of course, another piece is that we really, as healthcare providers, never recommend that anybody smoke anything. Inhaling smoke is bad. There are other ways to use marijuana, but again, that in my mind is really important if people are using this for medical purposes. The data, we're collecting more data all the time. The National Academy of Sciences just came out with a report, again, Cannabis in Medicine, which helped with some of the questions, didn't actually answer any of the things that I have on this slide. So we don't have a definitive answer, but we're getting more data all the time, and it's important to stay abreast with that. And again, the use of these concurrently, back to I'll keep hammering this point, should be focused on improving functional status and quality of life and ensuring safety. That really needs to be our ongoing goal with both opiates, marijuana, or the use of these concurrently. So I'll talk just a little bit about Medicaid. I was thinking, that clock isn't actually running. How am I doing for time? Okay, so I've got a few more minutes. Okay, so I'll address a little bit what's happening in the Medicaid population. Again, the Oregon Health Authority, I work on the public health division side of it. So I work for the entire, the entire population is my patient. But we do have Medicaid. That's another side of the Oregon Health Authority. So the next few slides will talk about Medicaid specifically, and they have implemented some of these within the CCOs and the fee-for-service part of Medicaid. So overall, there are 50,000 Medicaid patients who have back pain diagnoses. And more than 30,000 of those have received an opioid prescription. So again, this is a big problem in the Medicaid population as well. An average of 148 prescription days for those with back pain, so that's 6 months, with 5 million spent on opioids. So it's a big problem in our Medicaid population as well. So we have the Health Evidence Review Commission, the HERC, that was looking at, so what can best practice be? And they came up with these changes to the Medicaid medical coverage for opiates. And basically what they did was on the top bar here, they increased coverage for all of these alternative pain therapies that I had alluded to earlier. Cognitive behavioral therapy, spinal manipulation, both chiropractic, acupuncture, non-opioid medications, rehab or interdisciplinary rehab, supervised exercise, yoga, PT, massage therapies. There's a variety of here. And of course, we know that depending where you are in the state, some of these may be more or less available. So the asterisk there is that it's clear that there are more rural parts of the states where these aren't available, but these are covered under Medicaid. But at the same time, they decreased coverage both on surgeries that were done for back pain, as well as opioids and the epidural steroid injections for pain. Now again, this is a pretty complicated figure, and so I want, this is something you should really download and look at. But the guideline note 60 is really what indicates what opiate medications can be prescribed for those folks on Medicaid. So starting on the left, during the first 6 weeks after injury, flare, surgery, etc., have a prescription limited to 7 days, short-acting, try other medications first, and if they're, make sure they're tried and ineffective before you go this way, and have a treatment plan that includes opioids. So a lot of these are, again, along the lines of those, the opiate guideline. After 6 weeks and up to 90 days, 3 months, continue to have a functional assessment and really look for whether or not that status is improving on opiates. Try a number of these other alternative therapies, and again, look at the PDMP, urine screening, et cetera, to do risk mitigation. And again, still limiting the opioids. And after 90 days, opioids are not covered under Medicaid. So, I think that this is sort of how Medicaid has chosen to put the guidelines into place, to really focus on limiting, because we have so many of those patients, but making sure that we're all offering people alternative. So for those, of course, who are already on the high doses, there's a taper plan that's currently in place, and to try to taper those patients off of these high doses of opioids during this coming year. So again, a lot of folks ask us, this is what's covered for Medicaid, this isn't for all patients, but a lot of this is good standard practice, I think. Again, these patients are very difficult, so I'm not saying that. But at the same time, as we showed in the first slides, we're sort of dealing with some pretty strict measures because we have such a drastic problem. So switching a little bit to some of the other changes that have happened, last session, House Bill 4124 was passed, which integrates the prescription drug monitoring program within the health IT systems. And part of this was so that prescribers, pharmacists, and delegates can query the PDMP as part of the practice. So rather than having to get out of one medical chart, go into another, et cetera. The PDMP separately, which we know has a number of firewalls, and it was a little bit cumbersome. That in part has been done because of concerns about the confidentiality and sort of the firewall. So we're trying to make it more user-friendly, if you will. So it hasn't been implemented yet. The PDM Gateway will, so we're starting to do it over the next quarter here, to securely integrate the PDMP into the existing infrastructure, and that includes health information exchange systems, emergency department information exchange, as well as the health system data sets. So the folks who are planning to use still need to have that, the PDMP user account that can be signed up for. And there's a lot more information about the 4124 and how we're implementing that, again, on the website. So I had mentioned naloxone also as being kind of the rescue drug. We hope no one ever has to use this, but having it available is certainly important. So clinicians should consider offering naloxone to patients who have either a history of overdose, substance use disorder, or on higher doses of opiates, or using them concurrent with benzodiazepines. One of the things that changed in 4124, in addition to the PDMP, was that now pharmacists can prescribe. So it's not an over-the-counter medication. It's still behind the counter, but pharmacists can write the prescription. There has to be a training that the patients or whoever, it doesn't have to be the person themselves, right? Somebody can get it because they're concerned about their spouse or partner or friend or whatever. There's a training they go through, and then the pharmacists write the prescription. So this is very similar to other things that pharmacists write prescriptions for. Birth control as one example, some of the vaccinations like influenza or whatever. It's not that these are non-prescription, they're prescribed by pharmacists, so they're behind the counter. So there is a naloxone training protocol that we put together. It's on the web. And we also have a naloxone work group that's really trying to roll out some of this, not only with pharmacists and sort of the medical care system, but with other folks like EMT and law enforcement and other first responders who might be first on the scene for an overdose. So we have a couple of things in the state working at expanding the medication-assisted treatment. With some funding from SAMHSA, we actually have 3 new outpatient treatment programs in Oregon that are on the Oregon coast, Central Oregon, as well as the Southern coast. And a lot of this really is to do more outreach to the rural practices. Again, we know that there is much more availability of medication-assisted treatment in the Portland metro area, for example, and in the Valley than there are in other parts of the state. We also want to increase the number of buprenorphine waivered physicians who are actively prescribing, so that's the medication in the medication-assisted treatment, as well as doing education and outreach related to the treatment. So the point of contact for medication-assisted treatment in the Oregon Health Authority is John McElveen, and his contact information is here if folks have more questions about that. So I know the group had asked me to talk a little bit about this SAMHSA funding, which is the state targeted response to the opioid crisis. So SAMHSA has a lot of money out there, pretty much for every state, in kind of a I was going to say a proportional amount, and there's a little bit about how many overdose deaths you have, how big's your population, and what's available. But in any case, in Oregon, we're going to have a total of around $13 million, $6.5 million each year for 2 years. And most of this isn't going to the primary prevention that I've been speaking primarily about, but is for the treatment and recovery of folks who are addicted. So, and the purpose is, again, to supplement existing activities. So we're in the process of putting together a grant proposal right now. But it's one of these that it looks like, even though we have to put a proposal into SAMHSA, they really are hoping to fund every state who's eligible for this. So a couple of the required activities are Addictions Peer Navigator program within Department of Corrections. So one of the things, of course, people are not using these drugs while they're in corrections. That may be what they were doing before they got there. But there's really very, very high risk, of course, when people leave the corrections, correctional system and go back, because they often get back to the same environment that they came from, and that was often what led them to be using some of these drugs in the first place. And again, we have a fair amount of, there needs to be a needs assessment that's done also within some specific populations, such as tribal populations. And Mike Morris is the contact for that. So I'm just about done. I'll end with a couple here. We do have health system initiatives, so I really want to call a shout out. I know you all have one here at Samaritan Health, and these kinds of summits are actually happening around the state. And as I mentioned, the statewide guidelines are really as a tool. We can serve as a tool and to help everyone. The hard work has to happen at the local level and the health system level. So implementing those prescribing guidelines, developing pain schools so that people can learn how to manage pain in ways other than opiate, again, offering alternative treatment, the list, as well as the medication-assisted treatment. The coordinated care organizations, there's a performance improvement project related to opioids, which also involves not only I was going to say the indicators that are trying to be the metric. I won't call it an incentive metric because it isn't, money isn't attached to it right now, but to try to decrease opiate use within those, within the CCOs. So I know that Senator Steiner Hayward is going to be talking a lot more about what some of the policy changes are that are being considered in the state legislature right now. There are a number of possible enhancements that could happen to the PDMP, and there are several bills that are in the legislature right now. A couple of them include things like having required provider enrollment in the PDMP. We know that there are lots of people in it, but there's lots of people who are not, and so it could be at the time of license renewal, just as an example, that you automatically enroll. That it's a little bit of an extra process. It can't just be your license and you're enrolled, but that you that would be one of the requirements. Having automatic notifications when patients come in, so not just people in a patient start have to check the PDMP, but there's some push so that when you're seeing a patient, for example, in an emergency department, you know that they might be a frequent user or have gone to multiple places to get opiates. And then we, of course, are interested in being able to use some PDMP data to improve public health practice, to see where sort of high prescribers might be, and also within health systems, doing clinical practice improvement. I think there's nothing better. You know, all of us say, how much do you exercise? Oh, every day. You know, did you exercise this morning? Well, no, this was an exception. So, you know, the same with this. I use it all the time. Oh, except, you know, when you don't. So I think that kind of feedback loop is important. Other states have tried a couple of things. The pain clinic, again, this is different than pain school, but the pain clinic, I put it in quotes here because it's what people talk about as pill mills in some states. But there are standards for what clinics would have to do when they are prescribing these amounts. They could be registered and other things. We haven't had a lot of those in Oregon, but there was one in Portland a few months back that got shut down as being one of these pill mills. And then, of course, you get law enforcement involved in it. And then required drug take-back. There's, again, more bills at the legislature that are looking at different ways for drug disposal. So again, a busy slide, but this is just to show we are doing a lot in all of these areas: opiate prescribing, naloxone availability, alternative therapies, as well as use of data. And this slide shows the resources I mentioned. Our website, healthoregon.org/opioids, has a data dashboard, a website. You can click on drug, class, and region, so you can look at exactly what's happening with overdose deaths in your region, with prescribing, with hospitalizations, et cetera. PDMP has its own website, and the Performance Improvement Project for the CCOs has their website. And here again is a long list, because I'm not the only person doing it. In fact, there are lots and lots of folks at the Oregon Health Authority that are working on this. And so, again, I know you have access to these slides, but feel free, everybody's email address is on here if you have any questions. So with that, looks like I took 45 minutes. We have time for a question or two? Can you yell? Okay.
Corvallis Pain Management in Corvallis, of course. So I have a question about Medicaid in different regions. So the WVCH in Salem, we're contracted with, and I've been seeing patients there. And they're offering interventional techniques such as facet joint injections, facet joint rhizotomies, and even spinal cord stimulators. So I get referred patients from Salem for spinal cord stimulators and stuff. So I wonder, and this is Medicaid, this is WVCH. So I wonder if there's any data that kind of compares any outcomes, you know, between different regions. Well, I guess the first question is, why are the regions for Medicare so different? I mean, I was kind of blown away when I was getting these WVCH patients. So is there any outcome data?
Yeah. So are you talking about Medicaid under the age of 65, or are you talking about Medicare?
I'm talking about Medicaid.
Medicaid.
Yeah.
So the short answer is, I can't answer your question. So what Medicaid does, and you saw that the earlier slide, maybe I can figure out how to put it up, which about what was covered and what wasn't. So some of that surgery that you were alluding to is something that should not, I can't figure out how to do this. I'm used to having a mouse, so I'm sorry. But anyway, the number of treatments that were covered on Medicaid going up and down, but the surgery or these surgical type interventions are something that they are really trying to move away from. So I was thinking about, use the arrows. What a grand idea.
I mean, what we've seen with the Salem Medicaid, the WVCH, is they're moving pretty aggressively toward pain management interventions.
Yeah, and so again, I can't answer about, I don't know about the specific details about what's covered, but you can see that the ones on the left here are all non-invasive, right? And the ones that there's decreased coverage for are the more invasive as well as opioids. So when it comes to those specific details, you should probably contact one of the folks. So Jim Rickards was on the list. He's the OHA medical officer, or Kim Wentz is the Medicaid medical director. They know much more detail about exactly what's covered by which CCO, but this is what's supposed to be happening statewide, both through CCOs and through fee-for-service.
The reason I bring it up is it would be very interesting to have some outcome data between the different Medicaid regions and what they offer.
Yeah, I know that, let me find out. So the folks, Lisa Bowie, again, who's on the list, is our quality manager, and they do look at data. And we put out a quarterly report card for all of the CCOs on how well they're doing with all of their metrics, which include things, of course, like, the smoking status and, well child checks or whatever, the whole list. And so I can't specifically answer your question about that, but we are looking at how some of those things vary by region. But what I would say is this is the new paradigm, and so I would not be thinking, or I would think that they would not be offering some of those more invasive as part of this. Maybe it's part of the rollout. So.
Oh, thanks.
I had one question as well. Sure. Brent Godek, Primary Care Medical Director in Albany. You showed a slide showing decreased number of prescriptions just kind of edging down. Is there any state data on, instead of number of prescriptions, number of MEDs decreasing? We have internal data within Samaritan that shows that our prescriptions are starting to eke down like that as well, but the total number of opioid prescribed is actually dropping, so people are tapering. Is there anything on the state level to support that?
Yeah, so within that same data dashboard, and I don't have it up right now, but you can click on not only drug class, but these overdose, et cetera, MED, number of patients over 120 and over 90. So those data are specifically in. You can pick for your region. You can pick the number. So yes, that is one of the metrics that we do track, or the overall. So it's not the overall MED. It's the percent of patients that are on these kind of threshold MEDs. So we do have that. All right, thank you.